this next presentation is about sort of centering us in what we know about effective treatments for early psychosis. What is the coordinated specialty care model? And how do we want to think about this within our state? So what are effective treatment options for early psychosis? So first of all, we know that a core piece of treatment is boosting protective factors. So within our treatment, we want to treat symptoms. Those can be very distressing and impairing for folks who are impacted. So that can be psychosis symptoms, but it could also be anxiety, depression, sleep, a variety of things. We want to make sure we're encouraging physical health, sleep, diet, exercise. And in this area, we also sort of talk about limiting or eliminating substances like alcohol and other drugs. We want to limit stress, but also improve our ability to cope with stress, which is the next one. But limiting stress, adapting educational, occupational, and family responsibilities to things that seem manageable for folks as they're on the process, the path towards recovery. Sometimes folks need some changes there during their recovery period so that they can kind of get their feet back on the ground. So, and then improving coping skills. These two things go hand in hand. Helping folks have skills, cognitive skills, behavioral skills, affect regulation skills to help manage their symptoms or their distress. And then also it can be really important to do problem solving and support and enhance communication within the, I'm going to do air quotes, family environment, whoever that person's primary support system is, so that that system is functioning well. We also want to increase social support, and that can come from a variety of places. It can come from the clinical team, but can also come from the community, can come from clergy, extended family, friends, pulling in people for that individual's team so that they feel like they have support. And all of this is really in the service of recovery goals. You know, we're talking about symptoms, but symptoms aren't the only thing. They're just one piece. We really want to ensure that individuals are pursuing meaningful things in their life. As Dr. Tully likes to say, building a life worth living. So work, school, relationships, romantic relationships, travel, all of the things that all of us love. These are the things that we will work with on our clients. Then to do this, we use evidence-based treatments. So, and these tend to fall in particular categories, even though Dr. Tully and I argued about where they go and this different stuff. So they fall in general categories. So physiological can be medication management, substance use treatment, and always remembering to partner this with physical health. So making sure we're coordinating with primary care, and even so far as making sure our folks have a dentist so that their physical health is also being managed and supported. Then we have our psychosocial interventions. And so some of the evidence-based practices are things like cognitive behavioral therapy. This is something that our team has specialized skill in between Dr. Hardy and Dr. Tully and a number of folks on our teams. This is one area where we will be able to provide training and technical assistance. Individual resiliency training is sort of CBT light. This is the version of CBT that they use in Navigate. And so this is another option for programs. So then we have cognitive remediation, doing brain games, training your brain, exercising your attention, your memory, your processing speed. You know, as we know, psychotic disorders are neurodevelopmental brain illnesses. So it's not surprising that folks also have cognitive impairments that they struggle with and that impact their daily functioning. So having treatments that address these cognitive impairments is really important to the work we do. Social skills training is another evidence-based practice that we want to consider. And there's lots of different ways in which we can integrate these skills into the services that we provide. There's group methods for doing social skills, individual methods for social skills, just really helping our clients be able to go out and build those relationships that are important to them. And then really wanting to acknowledge the power of peers. This is something in California that is incredibly important to us. And so for us in early psychosis, we see this as integral to the work we do. And so peer and family support. So when I think of peers, I think of peers, client peers, and then I also think of family peers, you know, to speak to the lived experience of both groups. That's why we have peer family support, to have folks who can share their lived experience, provide that guidance to all of the individuals that we're working with, so that we can help them feel supported, understood, and like they're not alone, and that they have hope. So important, peers and family. Then we have our social environment. So the things that are outside the client and their family that we can also help with, so that the folks we're working with are able to be present and ready to engage in these other treatments that we're offering. Case management and linkage, linking them to other community services. I was just doing supervision with one of my clinicians, and we were talking about a transgender youth that we're serving, and how it's so important for us to partner with the gender health center that they're working with, to make sure we have that tight communication to serve the whole person that we're working with. So case management can also be getting them linked to CalFresh, a phone, housing, all of those other things that are, you know, basic needs that are important. Then we have services that are about getting back to work or school or being successful in those places. Supported education and employment, helping folks, again, either continue to be successful in the environments that they're in, or getting the supports they need at work or school so they can be successful. And then occupational therapy is an area where we also have this integrated within FEP to help folks maybe understand and remediate some of the physical or other cognitive challenges that they're having in the work or school environment. Coming back to family again, there's interventions that focus on family problem solving and communication. Multifamily group is an evidence-based practice, as is family-focused therapy. These are two wonderful evidence-based practices that, again, we will be supporting in our collaborative. And then family psychoeducation, and again, family in quotes, whomever that support network is, just helping them to understand what's happening and how they can be supportive of their loved one, and how their loved one's illness may be impacting them, and then what supports they may need. So really keeping that support network strong. So we do all of these things in the context of the coordinated specialty care model. This model was developed and has been broadly implemented in the UK, Australia, Canada, Scandinavia, and is now growing in the United States. And so it includes team-based coordination of care, outreach and education, early identification, and then this combination of evidence-based treatments for psychosis that I just discussed. We really focus on the earliest stages of the illness within the first 2 to 5 years, because we know that's where the biggest impact can be made for the individual that we're working with. There's lots of different versions of CSC. There's the peer program, the navigate program, the on track program, the EDAP program, the prep program. You know, there's a bunch of us out there, but we all sort of follow the same idea, which is we support the client, medication, variety of psychotherapies, family education and support, supported education and employment, and case management. We tested this approach in the United States as part of the RAISE study, which was started in 2009. Preliminary data came out in 2016. Now, I think it's really important for us to all keep in mind that while this study was amazing, it included 34 clinics in 21 states. Huge study for the United States. It focused very specifically on individuals with schizophrenia spectrum disorders. So schizophrenia, schizoaffective disorder, schizophreniform, brief psychotic disorder, and psychosis NOS. So here in California, that's not all of what we do. Many programs in California also serve individuals with mood disorders with psychotic features and individuals at clinical high risk for psychosis, meaning they have attenuated or subthreshold symptoms that are causing distress, but don't meet that threshold of full psychosis, or they have genetic risk for psychosis and are deteriorating. So this study is just for one piece of the folks that we serve. But it's still very important for us to know about it, because what it showed was that we can do this work in community. It doesn't have to be done at a university. We can do this work well in community sites. It also showed that folks who received Navigate treatment, as opposed to typical community care, were in treatment longer, showed a greater reduction in clinical symptoms, and greater improvement in quality of life and participation in work or school. So it worked for those things that we care about. However, treatment effects were moderated by the duration of untreated psychosis. So that period of time between someone having threshold psychotic symptoms, threshold hallucinations, delusions, disorganized thinking, and when they were accurately diagnosed and treated. This delay between these 2 points is called the duration of untreated psychosis. And for those of you who've heard me speak about this before, we know that individuals can be in treatment during this time. It just might not be for the right diagnosis. So this period in the United States is about 18.5 months. So this 74 weeks is what they saw in this study, because they took a bunch of people and they saw that 74 weeks or 18.5 months, that was the point. If you could catch people under 18.5 months, they showed greater reductions in symptoms and greater improvements in quality of life than individuals who had been ill for longer than 18.5 months. Now that's a year and a half. We really need to do a better job of finding the folks in our community and supporting them into appropriate care. 18.5 months is too long. That's not acceptable. Would not be acceptable for cancer or diabetes. It's not acceptable for psychosis. So when we think about it across the United States, there's a lot of heterogeneity in how CSC has been implemented. The ages of our clients differ. Some focus more on the adult side, like On Track New York. My clinic goes down to 12 and up to 40. The peer program starts at 14. Navigate starts at 15. Lots of diversity. We also differ in the stage of psychosis served. So some programs serve high risk, clinical high risk, and early psychosis, such as my program at UC Davis and the peer program. But some programs only serve first episode, like Navigate and On Track New York. Again, I've mentioned the diagnosis we could include also differ. Non-affective psychosis versus affective psychosis versus substance-induced psychosis. These are all choices that different programs have made. And then the specific evidence-based practices also differ. So using individual resiliency training and Navigate versus a CBT and family focus, family education and Navigate, multifamily group. So there's lots of differences here. And so one of our goals in working in California is to try to help us come a bit more into a common idea of who we want to serve and how we want to serve those folks. So a summary of the treatment standards that we know to date: coordinated specialty care. So everybody lock in CSC. We're going to use that term a lot. CSC is appropriate and effective for individuals with schizophrenia spectrum disorders who are early in the course of treatment. That's what RAISE showed us. The data also suggests that this combination of treatments could work for clinical high risk. So, some good studies that showed this combination of individual, family, supported education, and medication reduce symptoms and functioning for clinical high risk. Similar things in this study delayed the onset of psychosis. One very important point I want to make is that prophylactic antipsychotic medications have not been supported. So we want to avoid antipsychotic use in individuals who are at clinical high risk. We want to treat the other threshold symptoms, anxiety, depression, but we want to be very careful before they reach that threshold. And then once they reach the threshold, what my doctors like to say is start low and go slow. Be very careful when you get to the threshold, because you might be surprised how little medication it takes to have those symptoms reduce. CSC has not been tested in individuals with mood disorders with psychotic features. We have evidence that CBT plus medication, that is the recommended approach for major depression with psychotic features. And then for bipolar disorder, combinations of medication, CBT, and family-focused therapy are appropriate. So really this slide is meant to highlight CSC, the approach of choice, very well substantiated for schizophrenia spectrum disorders. In California, we do lots of things. Clinical high risk, mood disorders with psychotic features too. And there's initial evidence suggesting that the CSC approach should be effective, but it hasn't been proven. So I just want all of us to sort of understand these basic pieces as we move forward. So because of the Prop 63 dollars that we had available to us in California, we developed early psychosis programs very early. And again, everybody kind of went in their own direction. It was county by county. Some counties partnered with local universities. The universities in California have been working in this space for a very long time. There's incredibly well-respected researchers at UCSD, UCLA, UC Davis. We have Cam Carter, myself, and our group, UCSF. We have really great people in California. And so some counties partnered with us to develop programs, but other counties didn't. And so we've kind of all developed in these different ways. And then after the results of RAISE came out, SAMHSA invested through the Block grant dollar system. And that supported us further to enhance our programs or to grow more. So again, I'm coming back to the study that we did in 2016. This landscape analysis of early psychosis programs in the state of California, where we had 30 programs in 24 counties. 41% were active, 21% were developing, and 38% didn't have a program. Again, predominantly in our rural and remote areas. And so this is where we really began to understand the diversity of California's programs. So in 2016, 3/4 of them served first episode psychosis and clinical high risk. We were doing the full spectrum of psychosis. A small proportion served FEP only. And I know some of those programs now are considering broadening to clinical high risk. And then another small proportion were only serving clinical high risk. And I know now they're considering moving towards serving FEP as well. 86% served any psychosis spectrum disorder, including schizophrenia, with 3/4 serving mood disorders with psychotic features. And then even a small group who also took mood disorders without psychosis, like PrEP's Beam Up program. So really trying to innovate in this area, trying to push this field forward. We had folks who were taking what had been learned from RAISE and trying to apply it more broadly. We also had this range of duration of psychosis from 1 year. There were some programs at the beginning who were only taking folks who've been ill for 6 months to indefinite. So not trying to focus necessarily in that early psychosis population, but sort of taking all comers. And then we differed on how long we served people. Most of us served folks for 2 years. For a small proportion, it was only a year. And then for a quarter, they went to 3 to 4 years or indefinitely. We had a variety of different treatment models. There were some of us using the peer model, some using the Felton PrEP model, EDAP, RAISE, ESA, this is out of Oregon, and then a quarter something else, and then 7 who weren't quite sure. So as part of this paper, what we did is we use a fidelity measure called the FEPS, and we asked all of these programs, what components of care are you providing? And you can see the FEPS went up to 28, and a good number of programs were providing what was considered to be core components of coordinated specialty care. But there were a number of programs that weren't. And it wasn't that everybody was up here at the top. So we saw this as we have some room to grow. There's a lot of variability. People need support in getting to the best quality care. And through this work, we also realized a number of challenges. The CSC model is ideal, but it's really hard to shift from typical outpatient mental health to this. I know my program was implemented in Sacramento County's child mental health system. They were like, they didn't quite understand why our clients were so sick or that they needed a variety of things. We really had to work with our county to sort of help them shift in their understanding of what this team-based care looked like and how we needed them to help us figure out how to bill for the different pieces of care we were providing. This work requires a different staffing structure, different caseloads, different expertise and passion in your staff. And then, as I just mentioned, billing structures. And all of us have been struggling with this, from commercial insurance all the way to Medi-Cal and uninsured. So we've gotten a lot of questions over time about how do we do this? Like, how do we build this in our system in this state where we're all kind of doing it in isolation? And so one of the key themes that we want to communicate today is that the what needs to be the same. These core evidence-based practices need to be the same. But the how you deliver them can differ based on local needs. So for example, I'm partnering with some of our Northern California counties that are more rural and remote, and we're building a hub and spoke telehealth model. So a lot of our services are going to be delivered via telehealth, but it's the same services. Those clients are still going to get supported education and employment, access to peers and to family peers, access to groups. So again, the what stays the same, the how can change. Again, I really want to acknowledge the Oversight and Accountability Commission and DHCS for supporting us in moving this forward. They see the value and have heard our calls for help, that programs across the state need support. And so we are very grateful to them for that, and hope that this system that we're setting up and starting now is beneficial to all of you. So again, this is the framework that we have developed with your collaboration and your input. And we hope it continues to be useful moving forward. So you can see how today, we're going to be providing technical assistance, but in the future, we may provide clinical service for some sites who are having difficulty accessing particular providers. And then the learning that we're doing through the Learning Healthcare Network, a big goal of this is to identify needs, to understand what's working and what's not working in our programs. And an important piece of this work as well is understanding how clinical high risk and individuals with mood disorders with psychotic features are impacted by the work we're doing. We have a natural experiment happening here in California. We have a very diverse group of individuals being served, and we are going to systematically examine how our work is supporting meaningful change for these clients and families in the programs that are working with them. So hopefully today you can see how the history of what we've had in California and what we've tried to create through the EPI-CAL network is trying to not only provide the training and technical assistance that people have been asking for, but also answer some very important questions that our field has been wondering about for a while.